Okay,
Got it.
thanks.
All right, there we go. Okay, so the way I'm going to do this talk is kind of interesting in that first I will tell you what we did, then I will tell you how we did it, and then I'll tell you why we did it. So it's kind of, kind of a reverse action here. So the actual part about what we did is going to be pretty straightforward. Now this starts off from, you go back to March 24th last year. We have these articles coming out where New York Governor Andrew Cuomo is saying, we need all these ventilators. How can we get this to be available? He's calling us up saying, I need 30,000 ventilators. I need them now. And that is a lot more than we produce on a weekly basis, to say the least. So, it's like you have this push, and portions of our team were literally fielding calls from governors of different states trying to say how they could get access to medical devices in short order. But also in the beginning of this time, we're having these discussions about, all right, what do you do in terms of a triage type situation? There were not enough ventilators around to meet all the need. So there's articles that came out in the New England Journal, things like of all the medical care that will have to be rationed, the most problematic would be mechanical ventilation. One of the things they came up with saying that it would not be appropriate to allocate just on a first come, first served basis, but your decision on to whom to make these devices available should be based and responsive to evidence. So how do you find a fair way to share these devices when keep in mind at this time, even just the data we had available was problematic to find out. So how are you going to make good decisions based upon data when it's hard to get? So one of the things we came out to really quickly was saying, well, are we going to focus upon what might happen, model prediction? And again, even the inputs here are very sketchy. Or are we going to focus more upon what was happening, tabulations of cases and deaths? So we prioritized work on developing a fair algorithm for the dispersal of new Medtronic ventilators. And we decided that we were going to do more upon what was happening, but how exactly would we go about doing this? So, here you cue your 80s, 90s movie concepts of do the right thing, right? So whatever you do, just make sure you do it right. And it's amazing like how often people can get tied up more in the mechanics of a process and not just step back and say, what's the right thing to do? And so if you just sort of step back and say, all right, this has to be something that works for patients, that's appropriate and ethical, then that can guide a lot of your decisions. So we actually came up with a fairly easy way to handle this, is that we split the total number of new ventilators proportional to the number of new deaths that were observed over the last 7 days. We knew that we wouldn't fully satisfy any one area, but you would proportionally address the demand for all areas. And the algorithm responds dynamically to changing demand. This is at a time Johns Hopkins was being a good source for counts of deaths and cases. But interesting enough, it turned out that while they were a source, there was more adjudication going out from different sources. So the New York Times, back about a year ago, was a great source because they would go in and they would look for data anomalies, and they do some cleaning and scrubbing. And so actually, of all things, the New York Times was a great source for us to get at level data, not just the states. In some cases, it was available even the counties or some countries to work it. So we actually made an algorithm that was more responsive on counting up deaths. And I'll talk later about why deaths and not others. But the whole process here is that we wanted to have a very ethical approach that sends the most ventilators to areas of the most need. That was clear, that was intuitive and easily trusted by the community. And that was practical, that was readily put into operation. And so you sort of had to step back from all that was possible and say, well, what is feasible? What can we do? And is it something that is ethical, clear, and practical? So again, what you do is you have this state allocation procedure where it's proportional to the number of deaths in the last 7 days. But then even within the states, there's local allocation where you would target counties with the most deaths. And even within the counties, then sometimes you're also going after the hospital allocation. And you would go after open orders, hospitals that serve the target counties, especially when you think about things like the New York metropolitan area. You have multiple counties with large numbers of people close together, and it gets a little problematic, because a given hospital might be on the boundary between multiple counties and actually serve multiple counties at the same time. Furthermore, the way the ventilators are set up is that not every hospital has the capacity to take these in. Like one thing we found out later was that a real stumbling block actually ended up being the systems for pumping oxygen through the hospitals. You need to maintain enough pressure that the number of ventilator systems in serial could in fact be high enough to then force air into the lungs of the subject. So if you make this giant long chain, the pressure at the beginning had to be very high. And so because even within the ventilators, there in fact is a lot of configuration that goes on. So you had to make some decision weeks ahead of time as to how to build that ventilator so that it would go to a hospital that had capacity for certain amounts of oxygen, that had trained staff to operate them. But we had to work sort of, we start with the state fashion, target it down to the counties, because we did have county level data, and then within that, within the hospitals. In order to prepare for what was actually sent out, we did forecasts using a predictive model, and we were working with one that was based out of the University of Washington called the Institute for Health Metrics and Evaluation. So that was sort of the planning thing, but the actual decisions were coming down more from the proportional deaths by area. All right, so that's what we did. But the question is sort of, how do we do that? So this is, back to the future. Go back, think about what was happening at this time. Go back a year. There were a number of data issues that happened in spring 2020. So here we have an example. This is the China CDC Weekly, epidemiological characteristics of an outbreak of that novel coronavirus disease. And one of the things you'll see is that you look at those early dates, the end of 2019 into beginning of 2020, you're having that real fast ramp up in counts. But on the right-hand side, if you look at these plots, you're also starting to see that there's this ramp off and the die off afterwards. Okay, is that truly a passing peak? Is that just a data lag that you haven't yet tabulated all the persons that were positive at a given point in time? We didn't know this yet. And we also didn't know, it's like, well, how is this data going to apply in other geographies when it spreads? We were working with data from the morbidity and mortality weekly report coming out of the CDC. This one's from March 18th. And you're seeing this, you're going from basically 0 cases early on in February up to ramping up to close to 1,000 by mid-March. If you dig even further into the data, excuse me, some of the early counts were at a nursing facility in Washington State, and it was very clustered there. And so how do the dynamics of exposure within a clustered environment reflect exposure within community spread? So how much is your available limited information trustworthy and extendable? Some of the data sources we're using, I'm showing this picture on the right, it's literally a snapshot from a Twitter feed. In some cases, we were relying upon data that folks were posting on Twitter to get an early sense of, all right, what's the symptomatic rate like? What's the asymptomatic rate like? We just didn't know. And it's kind of easy to forget just how much we were working around in the blind back then. There was so much that was unknown, and you're in a position to make decisions really quickly with very imperfect information, and that's a challenge. And, to think about, this was something that was specific to last year, but the concept is something that certainly can repeat again. Certainly some other situation can arise where you're forced to make decisions in a very short period of time on imperfect information. How do you do that? This is just kind of to give way of background. One of the things I'd worked on in the month prior to the issue with the ventilators, we were starting to think about, a week or two before, we had a program at Medtronic, call center staffing. And the idea here, it was actually modified from something we have for heart failure. In the heart failure population, we offer a service where a nursing call center will periodically make calls to patients with heart failure and update them with information for how they should be treating their disease, or getting information like if you've had sudden changes in weight or other issues, and saying, well, how your care should be changed. So we already had this model set up of a bank of nurses that were associated with a call center. And the question was, all right, could we modify that? So we could give advice to persons potentially exposed to COVID-19, wondering how they should be treated. Okay, that makes sense. Well, let's estimate the number of nurses we need at the command center over the course of the COVID pandemic. Well, that depends on a lot of things. It depends on how many people get symptomatic COVID and when. Also depends on, are you providing this for the entire population of the US? Are you providing this just to those covered by Medicare? Are you providing this maybe to employees of some large company that has a contract with you? That matters. But there's, currently this big gap around the virus and the extent to which it's spreading. A lot of models out, reported or suspected cases. This does not equal true cases. We don't know how many people will get COVID over timing, so on and so forth. A lot of assumptions. And so what I'm just going to show here is just, some of the way you went through that early on. So we had some information from the Imperial College. They had come up with some information about modeling the impact of non-pharmacological inventions, NPI. And so they said, okay, well, we think that you would reduce the need for critical care beds, the ICUs, intensive care units. It's usually a count of the beds, by about 68%. All right, well, suppose we have a hypothetical unmitigated case estimate of 200 million. We get a reduction, go down to 64 million cases. You're spread out over a slightly longer time period, 4 months as opposed to 3 months if it's unmitigated. But you're throwing these assumptions in that are just so rough. Doubling time, 6 days, sure, we'll go with that. Examine settings, you can look at, well, what if you're down to, instead of doubling time, it's 1.8 or 2.0. In this case, you're assuming the curve is symmetric in numbers and that the peak occurs at half the total cumulative incidence. We're talking that there's 140 cases. Remember that there was a time where we're talking, just a few digits in cases involved way back when. Total confirmed case around 10,000. This was assuming that the total population in the US that would get it would be 64 million, right? And in this setup, the total number of cases changes based upon this initial multiplier. The total number of nurses needed scales by several things, proportion of the population being covered, probability of infected cases, we'll call it, time of average call it, so on and so forth. But you can take this information, you can plug it in, and you can say, all right, what's this look like? Well, we think that, the overall maximum load here is going to be, up in this value. And this is saying that, well, if there's 10 million total active cases over time. You start with this optimistic setting saying, well, in total, I'd actually need just over 1,800 nurses to staff at the peak. But that peak is over a really short period of time, right? But you still would need that many people if you're going to guarantee coverage. Or you could alter the proportions a little bit. Oh, excuse me, one more thing. So the lower bound, this came again, remember I showed that slide from the morbidity mortality weekly report. We're pulling in that estimate to give a feed into the lower bound. But you have the same figure, but different impact for the nurses. Because remember I said things scale linearly with your assumptions. So maybe you need 4,200 nurses at your peak. Or you go in the severe cases, you might need 28,000 nurses needed at your peak. And we know these are just rough approximations, but this is the sort of thing when the business is coming to us and said, we need to make a decision here in the next week. Put together a model for us, tell us how the disease is going to work out, tell us what the impacts are. And this really becomes just an exercise in telling people the impacts of their assumptions. It's not that we believe that this was the actual course of the disease, but it's like, okay, if you think the range might be this, here's the result of those assumptions. Here's what you get, right? And this is a period of time too, when I literally was being asked to review models that are being developed, by groups at Berkeley, by Iowa State, by, University of Washington, by the Institute for Health Metrics Evaluation, all over the place. I remember one that I saw, it was just a pure exponential growth model. And if you scroll down to the bottom of this Excel sheet, they literally had rows that had counts of over 3 trillion people infected with COVID. That's a real good trick, given the carrying number of our planet, not even hitting 10 billion. It's 3 trillion. It's like, okay, maybe you need to step back a little bit from the model and think about what the actual inputs here are, right? So it's just, these were wild days. This is just a real interesting experiential thing was going on. Go back to the ventilator action now. Remember we were talking about ventilators? So, within this was the setting where you're asking for help. And there's some more complications too, because in addition to our large ventilators, There was, we were working with Elon Musk and we were sharing our design. We made it open source, and there are groups that are making these low cost ventilators. And there's even more nuances. Like there's a level of product that we provided directly to FEMA, the Federal Emergency Management Agency, that was in charge of distributing. We had others, the larger units that we were taking the lead on distributing. Plus, like, as I mentioned, we made our plans open source so that others could build them and make them available. So there's lots going on, but I'm just kind of focusing on certain aspects of the problem that was happening here. And again, we're trying to do this ethical, clear, practical approach where you're allocating proportionally to the patients that need the invasive ventilation. Our footprint was used only to determine the ability to deliver, service, and train. Because one of the concerns was, are you going to send ventilators to preferred customers or something like that, right? And so you can't have that sort of consideration way into this. You don't want someone to think, oh, I'm a straight up salesperson, so I can make a ton of my commission by getting hold of all the ventilators and send them out. No, we're not going to raise the prices on these things. We're not going to set it up. We're not going to do more profiteering type things in this area. And so, all right, well, that's fine, but how do you make it happen? So again, our key assumptions was that we don't have enough ventilators to meet demand. If we did, we'd just fill all the order requests, but that's not happening. We also assume that no single region is close to covering the local demand with the existing installed stock, right? So no one is about to be fully covered. You don't have to worry about, if I give just a little, then you're good and I can pull you out of the pool. We also were not talking about moving around existing installed stock. In principle, that's something you could try to handle, but that gets really, how do you find out both what has been sold and what's maintained and what's available and who has the rights to it, everything else. New things are something that's a lot easier to handle. We do have access to daily counts of new cases for any area where we might allocate new stock. And then for any set of K, an index of areas, and any time T, we know the total number of new ventilators available to be allocated at the time T across the set of K areas, right? Because we have information on the manufacturing line, because the high-end ventilators are actually being constructed in Galway in Ireland and are being sent to the US. And again, that doesn't happen overnight. There's a lead time that's needed. So how do you prepare for that? So this again is that picture I showed you before, how it breaks down state to county to hospital. So you start off, you say, okay, for those areas, you determine the number of cases within that area over the previous 7 days, divide each of these counts by the total of all the counts. You multiply the fractions by the total number of new ventilators, round each of the results to the nearest integer, check for consistency. All right. But then if you really want to do this, it actually gets more complicated. Okay, well, the sub areas need to be divided by the total number of deaths in that area, has a vector of fractions. For each of the fractions, you multiply it by the total ventilators, got to round those to the nearest integer, calculate the sum of those results. If it works out even, you're fine, but maybe the sum is actually greater than the number of ventilators you have. Okay, well, I've got too many ventilators. Well, which ones do I pull? Well, then you have to think about, well, you order the difference, where you rounded the most. You start taking those out. Then you start looking at things at taking ones from where there's the biggest gap and try and make it work. Or maybe it's too low and you actually have a few extra ventilators. Well, who gets those? Do you just put those all in New York, or where do you put them? So, again, this is the idea here, is that this has to be a fair process and you cover all your bases, and it just gets messy, but it is something that eventually you can do. So you can split all the total number of new ventilators. It's proportional to the number of new deaths observed over the 7 previous days. You don't satisfy one area. It's a focus on the allocation of new devices. It can be implemented actually very easily if areas, sub-areas, sub-areas, because we're also in discussions about what happens for sending it to other countries like Europe. Or, do you handle it just by states? Do you handle it by counties? How do you go forward? And you have the capability for this to be extensible in those directions. But you still also need to do long-range planning purpose. And for long-range planning, there's this idea that you can substitute a model to project case incidents by areas rather than by recently observed case incidents. That makes more sense if the final decisions are based upon the observed data rather than the model predictions. So, this is an eye chart. I'm not asking you to read it. I'm just going to show that it's up there. And the idea here is that, we actually went through multiple potential allocation rules. Do you use the current deaths? Do you use deaths from 1 week ago, 2 weeks ago, 3 weeks ago, 4 weeks ago? Do you use cases? Do you use models that predict on cases? Do you use models that predict on ventilators? Do you use models that predict on ICU usage? Right? Once you got the framework up, it was fairly easy, relatively, to talk about how that would impact these different approaches. So this is an example where you have a reference date of March 31st, you have 100 ventilators split. This is data from April 3rd last year. You have the IHME data from April 1. You have the allocations for within the columns. And like if you look, for instance, say in New York, and just kind of see down here, actually Washington might be more interesting for this audience. So if I was going on 4-week-old cases, proportionately, Washington had a high number of cases at that time. So they would have gotten 34 of the 100 ventilators. But 4 weeks ago, when this is starting, they had all of the deaths. So they would have gotten all the new ventilators. But that's a month old. Does it still make sense to send that? Well, so if you take it based upon 3 weeks old deaths, then they get 67 of the 100. Or if you take it on 2 weeks old, they get 35, right? And so you can see how this changes depending upon the proximity of time you're using for your prediction. So certainly things that are more current in time, closer to where you are going to be less variable in terms of a difference between the prediction and the actual. But on the other hand, you can't just make the decision tomorrow which things to send. As I indicated, these are manufactured in Ireland. They have to be set up for different hospitals. And so I do have to have some idea of roughly how many it's going to be. And so for preparing to send things, we were using this model that was developed through IHME for saying, well, what do we think it's likely to be? But then the actual numbers ended up being a function of how many deaths had happened within the prior week. Right, so you set it up that way. Now, the funny thing is, despite all this sort of trauma that went into setting this up, it really ended up covering a period of 2 months. So what had happened was, it took us we had to get alignment. We developed the model over the course of about 2 weeks. The problem came in, you worked with you did model assessments, you got buy-in from stakeholders, you did different evaluations. And then once you came up with something, then you had to run it around the company. Medtronic has about 90,000 people in the company. There's lots of people with opinions, even if you're restricting it to senior management. But we managed to, get the process set up by the end of March. So then we had our weekly clinical allocations. And then this is a function of what happened in terms of the US deaths that was being thought. And then you've got the weekly clinical allocations going on. And after that period of 2 months, then we switched to firm delivery commitments. So we were transitioning to a point where, because at some point people want to say, if I'm a governor of Rhode Island, I've placed an order, can I get those? And so the thinking was at some point, yes, you actually have to say, okay, people that have said they want product can get the product. So this is all work that applied over a course of 2 months in 2020. So eventually we phased it out. We went from that, to the open orders. And this is thinking, oh, well, this is just for the first wave. And, we've seen what's happened since then. And so it's just kind of wild in retrospect, everything that's gone into. So this also just kind of shows at that time the difference between how you might have predicted deaths from 1 week out, 2 weeks out, and 3 weeks out. Right. And so you're seeing this is in a period of time where New York had this very big spike, but then it started going down. And so there's a difference in terms of what you might think that is 1 or 2 weeks out. And here you're also seeing just a little bit the hint of the fact that there's different ventilator models. The PB980 is the largest, more expensive one that we're really focusing on. But there are other ones, the 560s that aren't being showed here, but the federal government is just getting all of those. We're sending to FEMA, and then they're moving them as they want. But it was interesting in that this whole process of allocation was something that we'd also recommended when it came time later to talk about vaccine allocation. Who gets what? We're like, we worked on that problem. Talk to us. We're ready to talk. But different people, different staff, different answers. So now I'm going to transition a little bit more to some of the other ways in which you could do your epidemic modeling around this. And there were a lot of really neat tools that people developed, especially things with these epidemic calculators. And a lot of people did variants of what's called an SIAM model to predict future COVID-19 mortality. And this says you're breaking your model up into 4 main components: susceptibles, right? Now, this was actually fairly easy with COVID-19 because the current thing was that all humans naive to the virus were susceptible. Then exposed. Well, who actually could potentially be exposed? Well, hopefully social distancing measures have some impact on that, right? But that's a variable you can apply. How about infection? Well, even if you're exposed, if you're using personal protection, then hopefully that reduces your infectivity rate. And then you've got removed, which is sometimes a euphemistic way to say die, because if everyone has possible, the only way you're removed out of the equation is if you die or hopefully recover, right? So that's the sort of major thing that's set up. But the rate of transmission is the thing that you're really trying to move out. And so you can get these calculators that show color-coded, like how these things contribute. And this was one like a JavaScript type thing where you could just go in and change the numbers and see the impact. The state of Minnesota, where I'm at, they came up with a model that was essentially one of these SIAM models, but removed has been split into hospitalized, intensive care unit, dead, and recovered. They also stratified by 9-10-year age groups, right? Because they were already starting to see that there's a real difference in terms of how people perform based on your age group. And what they're not talking about here, and I had some conversations with one of the developers for this, there's a point in time early on where something like 86% of all mortality was happening in group living situations, nursing homes and the like. But they still didn't choose to implement that within their model. And so what they did, they kind of had the stratification. They also did the presence absent comorbidities, but then they take all the associated proportions, they scale it to Minnesota values, and then they adjust the parameter values until a close match is seen with observed, right? They're like, okay, we believe it's this way, and we're just going to tweak things till it looks good enough. That's the approach. But you still have this situation where, early on, we're having conversations about what to do, because remember, this is all being done like in March, April. We've got this estimated cumulative infected proportion. And the whole idea at this time was, a flatten the curve, keep it that we don't have this early spike of cases. And the idea being that if we pushed out this initial peak, by the time summer came along, you would have had the chance to manufacture more ventilators, have more hospital beds available, and it could be treated better. But it's how well does this work? So states like Minnesota and others, we're trying to come up with science-based models to make these discussions, but they're still just they're models. So then you have this situation where you have the mortality that's expected to rise in the short term, and you can go things between, all right, well, where's the model uncertainty? What is the actual case data goes? And so early on, you're okay, but in the future, well, it actually didn't track that well. So if you have a model based upon an earlier point in time to see how it landed. But then, when they're doing their simulations, it's like they were assuming in this case that the shape was exactly the same, but all they're varying is basically the size of the peak, right? There, you can see the two parameters effectively that they were considering changing in these models. Different people use different levels of complexity, but this is what this team was doing. But then, the governor is taking indication in terms of, well, what do you do in terms of SHOs, stay-at-home orders, right? Well, okay, if you have the stay-at-home order and then you have a particular scenario where if you extend it for everyone by 4 weeks, then we think that it will be 16 weeks. You're extending that time to the peak. 16 weeks also for that ICU peak. What does that top ICU demand look like? What does that top deaths look like? And that these numbers on an absolute scale haven't made a whole lot of sense with reality, but proportionally, maybe it's appropriate. When I actually remember sitting on a plane way back when I still did that in February last year, next to someone who was actually from a respiratory unit in Shanghai. And he had this slide he was going over talking about the possibility of 12 million deaths in China, right? And at the time I was just like, wow, bummer for China. I really wasn't thinking about bummer for us. And you don't know, right? And the assumptions apparent then versus what they are now, you don't know. So there's also this IHE-ME model that was set up from Minnesota, and this is one that we used in part to help our prediction. It's something that was frequently revised. Last time I was checking, which is a while ago, was doing it about every 4 days. They'd modify the model, right? Not just modify the data, but the actual terms of the model. Their approach was different than the SEIR models in that they primarily worked through curve fitting. And this is actually, they took the cumulative incidence of cases and said, we're going to match that with the cumulative density function for a normal distribution. And then we're just going to try to align that ramp up in cases till you get to the peak. And then we're going to assume that once you get that peak, that then it'll drop off. And this is based upon, the early data we had seen from Wuhan and Korea. Remember one of those early slides I showed from the China CDC where they had that peak going down. We didn't know for sure if that's actually going down or if it's just the delay in case counts. But this is how this model is primarily working, through curve fitting as opposed to the epidemiological first principles. And so with additional volume and types of data, then the model was able to become more complex. They did pre-processing of the inputs, including death counts, to clean up the data that was coming in. They started considering things like hospitalization, amount of mobility, the air temperature, testing per capita, percentage of population living in dense areas, differential effectivity of interventions. And they made this available for all US states and multiple countries. Quite frankly, the availability of the data is one of the reasons why we ended up using this as an aid in our prediction, because it was there. I mean, one of the leaders of this group previously had a background as a career in media relations. And so sure, if you get a media relations specialist telling the world about your models, you might have better uptake with the non-specialists than just speaking to the modelers. Something we learned out there. And this particular place treats different regions independently, adjacent states, completely independent, didn't have any correlation that was set up there. And it assumes social distancing measures stayed in place through August last year. The University of Texas had another one for model from Minnesota, was similar to that late March version from IHME, essentially the curve fitting mortality. But they were looking more upon actual daily deaths as opposed to cumulative deaths. With the cumulative, there's more dependence over time because you actually have to think about the independent increments that lead to the cumulative sum. So they're finding a way to get rid of the get better independent errors. They cap their forward predictions at just 3 weeks in the future, but state they only trust it up to 10 days out. I'll come back a little bit to sort of how far in the future you might trust these models. They assume the social distancing from the prior week maintained going forward, and they use mobile phone data to determine current social distancing, right? Because there's a difference between a social distancing policy and social distancing actions. So yeah, maybe you can use social phones and say, well, how often are things pinging the same cell tower? Iowa State, then had an additional layer upon this. So they started with the SER type model, but then they said, okay, we have this temporal structure, but then we'll enrich it by having a spatial temporal structure, but then also adding covariates. So they're working with county level data. They have spatial dependency. They have local control factors and covariates, and some of their covariates included population density, the African-American ratio, because we had seen, that there's actually differential effect by the ethnic groups, Hispanic Latino ratio, urban areas, numbers of hospital beds. So, they can come up with models like this. And it's interesting how you'll find something being conceptually appealing, but again, it's also a function for utility in terms of, can you access this data for yourself, right? Or do you have to rely upon the release of the models to do something with it? Part of the reason that this team was successful is that they not only had this concept, but they had actually done some work in the background that allowed them to maximize this complex function that they were specifying as part of the model. You can conceptualize the model, but if you can't actually fit it to your data, estimate your parameters, it's not going to be so helpful. And certainly there's a great amount of variability, across the models at a fixed time and across time for the fixed models. The shape of the models were generally agreeing in that exponential growth period. Early on, everyone's like, oh, it's growing, let's call it exponential. But as I indicated, people weren't careful. We have trillions of humans with infectivity, kind of hard to have. But the things with the exponential growth, if you have very small difference in model parameters, it yields very large absolute difference in your estimates for your counts, right? You can be just off a little bit of your slope, and you can see the impact in terms of total number of cases that are going on here. And we know that model fitting near peaks or minor bumps yield tremendous variability. And the long-term forecasts are increasingly driven more by assumptions than my current data. So if you start looking off to how the different projections of US deaths have changed over time, this is something nice that came out from the New York Times. You can probably still access it, right? So here's the early bit. And then it's just a question of how strongly do the models assume that things are going to taper off. Some of them don't, some of them do. Some of them see this big shift, right? And it's really hard to get something accurate when you're expecting this sort of phase change to happen within here. And what we've actually seen over time is that it's there's been multiple peaks, valleys, and how it goes. So I haven't even gone back to see what the current predictive reliability is like. So in terms of the overall model development, this is something that a former classmate of mine developed. He posted this thing where saying it was illustrative to examine the performance of the current models when using different amounts of data. So what happens if you use all but the last 2 weeks of data, or all but just the last week of data, or all currently available? And so then you can say, all right, well, how do those curves match? The color coding corresponds to the amount of time you're using. And here they were looking at the model from the IHME and Imperial College London models. This is in late March from last year. And what you had seen, so the IHME one is up high, and then the ICL one is down low. And the IHME seemed to overstate the precision of their forecasting, what they were going to get, with major deviations past 2 weeks in the future, and this is driven in large part because they're assuming the counts are going to go down. And that is an inherent part of their model. You'll hit a peak and then you go down. And so if that has to happen, then you're probably doomed to have this big gap. The Imperial College London model wasn't built in quite that same way. So, the actual counts weren't tightly aligned with the prediction, but they were closer to the stated level of variability. Whereas the IHME was like, oh, no, there's no variability. This will happen, right? So different things. So I would say that the stated variability of the ICL output was more believable. And so this really just comes to kind of the closeout for the talk, really, is that the models continue to improve, but the long-term forecasting remains suspect. We were in this situation here where we were forced to make decisions. We had to act. We couldn't wait any longer. And you had to make decisions based upon the best available data and the models you could develop in a short period of time. Sometimes it's just very rough. It's like, okay, you're going to tell me you believe that. Here's the consequence of that assumptions. Sometimes it's fairly sophisticated. Sometimes you're allowed to take in quite a number of different predictors or things that could impact your overall conclusions, sometimes not. But it also really mattered at the end of the day, not just what teams were doing, but how they let other non-team members know about it. How do you publicize your results? How do you make it accessible for other people to use your data? How can they apply it to their own specific areas? So, this is just an example of some of the things that we were running into, coming down to try to solve, inherently what should be a fairly simple problem. I've got a bunch of ventilators. Who do I give them to? But this was in a time period of it mattered who got what, and so we just said, all right, we're going to do something. We're going to work with deaths. It's very unambiguous. They're safely reported. You don't have to worry about testing too, because one of the reasons we didn't use test results is this is starting to be right at the period where people were ramping up the number of available COVID tests. What if some state suddenly releases a whole batch of tests and you have a bunch more positive cases? It's not that the virus is worse in that month. It was that you just have accurate information about the cases. But the death counts, that was seen to be more stable, even in the face of possibly changing testing effort. So we said, right, we're just going to work with the proportion of the counted deaths as the main driver for how we send out the ventilators. And so this is just, again, this full summary that there's a variety of ways in which you can address these problems. And sometimes you just have to go back to those simple, understandable things in order to have something that is understood not only by the experts, but especially by the layperson. So with that, I'll move to the question answer. And I do want to make one final comment. So I've got my contact information here at Medtronic. If you contact me within the month, this would be a great way. But I'm actually in the process of leaving Medtronic, and I'll be going to a different company. So you can at least reach me through my personal Hotmail email account here too, if you have any questions and want to follow up. So with that, I'll stop and happy to take any